Okay, and I'm going to put you over to the side, otherwise I can't see the screen. So if you do have anything you want to say, you're just going to have to say it because I won't see that you're trying to say something. All right, we're going to talk today about our treatment protocol for working with kids and families in the child welfare system because those of you who are fairly new out of school or who've been working in other agencies in other areas are certainly going to know that this is a very different way of working with clients. So, and that's why we try to do so much training. We try to do so much support for you because we know that this is difficult. So we're going to talk about the things that you need to work with this population. And some of it, honestly, is personality. If you're a very rigid person, if you've got to have everything lockstepped in place, this is not the place for you to try to work because there's too many moving parts with these clients. And those of you who have been in other, like if you've been a case manager, if you've been a GAL, you've been a targeted case manager, you've been a CPI, you know exactly what we're talking about, that these are different cases. They're very challenging cases. Yesterday, we were staffing a sexual trauma case. And one of the things that became very clear is that if there were 42 layers to the onion of this case, we've only got the top layer. So we have therapists that are kind of working blind sometimes, and we're going to talk a little bit about that. We're going to look at the treatment protocol that we have put together for dealing with child welfare clients. And we're going to look at some of the ethical issues. So we have a lot to kind of get into. But for those of you who've been around for a while, the child welfare picture has changed quite a bit in the last probably 8-9 years. The poverty and substance abuse and domestic violence, that's what brings all of our families into the system, isn't it? That's why they're here. But probably in the last, I'm going to say 8-9 years, parental substance abuse is the number one reason why kids are coming in. And I don't have any more recent numbers. I tried to find how much we spent last year on combating opioids, and it's mostly opioids, and I couldn't find it. When I originally did this, it was 2017, and at that point, we had spent $500 billion trying to combat opioid addiction with our parents. Since 1971, we've spent $1 trillion, and we aren't doing very well. If you follow this on the news at all, in 2021, 100,000 people overdosed and died from opioid addictions. So what's happened is that all these kids are pouring into the child welfare system, and we're not really ready for that. We're not really ready to take care of a lot of these kids because how do these kids look different? If you work in addictions, and I know that many of you came to us from working in addictions, then you know what I'm talking about when I say that these parents often are not making the choice to abandon their kids. They're not making the choice to just leave their kids behind. They are often truly not able to crack the addiction problem. One of the trainings that we are going to do this year in 2022, we're going to repeat the training that we did on the opioid crisis. And it's a doctor, I forget his name, Dr. Charles Adkins, I think, does a really good job explaining physiologically why a lot of these parents just cannot get off these drugs. And why, when these parents come out of drug rehab centers, that their risk of relapsing within the first 48 hours is extreme. And what does the addictive parent look like? It's not that they're abusive. They often just don't take care of their kids. So what we have coming in to the child welfare system are kids that have had no care at all. If you look at if you look at the CBHAs on your clients, they all kind of read the same. And what you're going to see is that these parents have been addicted for a while, and it's always the same story. They always say that they were working in construction, they hurt their back, they slipped and fell in McDonald's on the grease trap. Whatever it is, it starts them on that path to opioid dependency, and then they're gone and they're not getting off. And they are continuing to have children, but the children are just not cared for. And we get these kids that have either been stuck in a bedroom, locked in a closet, they're out in the middle of I-4 running down the street with their diaper because nobody's paying any attention to them. The treatment problem that we have with kids who are coming into the system from addictive parents, number one, you need to look in that history to see when did these parents become addicted. So if you have a kid that is now coming into you at 7, 8, or 9, whose parents have been addicted since these kids were 2 or 3, these kids more than likely have had almost no care, which is different than the kids that we were getting 20 years ago. Those kids were physically abused. Well, many of them still are. Those kids were sexually abused. Those kids had pretty severe abandonment issues, but those kids got some level of care. It's different than the kids who get no care at all, because number one, for those of you who are doing adoptions, and we do a lot of adoptions, kids that come into the adoptive placement, having been raised by or unraised by addictive parents, don't expect anything from their caregivers. Kids who come into group home setting, kids who come into foster care are not looking at those caregivers as caretakers. They just assume they're going to get nothing because that's what they've gotten. So that's kind of how our child welfare paradigm has changed over the last probably 8, 9 years. Um, we definitely still see all this other stuff. I mean, God knows we're hearing an awful lot about human trafficking because last month, I think, was Human Trafficking Month, and everybody and their brother put out seminars about human trafficking. So, and a lot of these kids are trafficked by their families. Why are they trafficked by their families? Because their families need money for drugs. So it's really changed our whole way of looking at child welfare. And we have addictive parents who are not necessarily being abusive. They're just unavailable to their kids. For you, always be thinking about your treatment options. Always be thinking about how you're going to approach treatment with these kids. They don't expect anything from you. And they haven't been wired to expect anything from you. The other thing you need to look at, for those of you who are working with the little kids, I don't see Dina on here, but some of you work with the 3 to 5 population. But even after that, there are very few kids who are coming in now that don't have some kind of either in utero exposure to drugs or exposure after they are born. So why do we need to look at the in utero addict? For one thing, the thing that I see everybody overlooking a lot, when you're doing the in-depth assessments for the kids 6 and under, you really, really need to look at prenatal history. And you need to look at whether or not these moms were using, and what were they using and when were they using it during the pregnancy. The absolutely worst thing for children is alcohol. And if these moms are drinking during the pregnancy, there's certain parts of the pregnancy that it is a lot more dangerous than others. The first trimester, when people sometimes don't know that they're pregnant, can be very, very damaging. But we need to be a lot more aware of the side effects of drugs. If you are going to do anything when you're pregnant, the best thing you could do is smoke pot, because pot has got the least amount of side effects of any of the drugs. Almost all of them, whether it's cocaine or opioids or heroin or whatever it is, are going to show up in children's behaviors and self-regulation problems across the board. With a lot of it, the drugs get out of their system, it goes away, but these kids maintain self-regulation problems. Now, what does that mean for you guys? What does that look like? What does the lack of self-regulation look like in kids that have come into care? And what are all of our kids being medicated for? once they get into care, especially once they get into the group home setting. It's just a given that they're going to get diagnosed with ADHD and they're going to be medicated for that. With a lot of our kids, there's two reasons for the lack of self-regulation. One is that most of them probably have had some exposure, either in utero or right after. And the second thing is that nobody's taking care of them. So,
I've noticed something that like a lot of what's happening is neglect, and what you see is a lot of attention-seeking behavior.
mhm.
And so I feel like a lot of ADHD is being misdiagnosed because it's really just the child is seeking attention because they've been neglected so much by a caregiver that they just don't know how to behave properly to receive attention in a positive way.
And Stephen's exactly right. I mean, many of our kids are misdiagnosed with ADHD. It's just easier. I mean, let's face it, it's easier for a psychiatrist. Nothing against psychiatrists, but they don't have a lot of time. They're looking for a physiological cause for the behavior. The easiest thing for them to do is to medicate. And in many cases, it doesn't hurt them. It might help regulate them, but the cause of the lack of regulation is what Stephen just said. They just haven't had anybody to care for them. So think about, for my circle of friends, people, um, kids that you're starting to see in therapy that are presenting with behavioral symptoms, presenting with ADHD symptoms. You've got foster parents that want you to take care of these kids and get them to stop behaving the way they are. This is a very this this behavior, the causes for this behavior goes back very far. So what we have right now in Florida is the safety methodology protocol. If you are aware of that, if you work in child welfare or have had any portion of working in child welfare, for the last several years, the CPIs going out use the safety methodology protocol. And what does that mean? What that means is that they're going to assess the what would they call that thing that they send us, the functional family assessment. They're going to assess the ability of the family to take care of this child. They're going to see if what they're trying to do is avoid removal, and I get that. But they're going to look at it and say, can this parent, with appropriate supports, an aunt, a grandmother, somebody from the church coming in, can they provide care for these kids? Now, where does this disproportionately affect our little kids? Kids under 5 are much more likely to be removed because they can't protect themselves. If you're 14 and you're living in a house with an addictive mother, you can get up and leave, and that seems to be the sad way Florida looks at it. But if you're under 5, you can't. So what we're looking at, our child welfare removal system is removing younger kids much more frequently than older. We do CBHAs here. I rarely get a CBHA on a child that's over 4 or 5. Once in a while. More than likely, what we get are kids that are 4 or 5 months old, 2, 3 years old, that parents just they were not able to pass the functional family assessment enough so that the kids could be kept safe. So we're also going to see much more a higher level of neurological deficit in kids that have been extremely neglected in the early years of life. Now, you guys have all sat through that training that we do at the beginning of every year about the effects of trauma on the development of the brain. So if the first 2, 3 years of your life have been in a home with addictive parents who are not taking care of you, who are not taking care of your physical needs, who are not talking to you, who are not helping you to develop the things that you need to develop, the ability to interact, the ability to connect with people, you are going to have neurological deficits. And all of these things you all have to factor in when you're trying to assess these kids, which is why we do this training, because it is not for the faint of heart. We are going to look at mental health. The reason that we do the trainings in mental health is that understanding what happens in the first 5 years of life, even if you don't work with kids that are under 5, is critical for you doing this assessment. You have to understand what happens to that kid's brain in the first 5 years of life in order for you to assess and develop an accurate treatment plan to treat these kids. You're going to see bonding and attachment interrupted. Um, and and again, since most of you are either already adoption competent or you're going to be coming into the next adoption competent trial or training, you really need to understand that kids that are coming into the adoptive sequence when they're 7, 8, 9 years old are not going to be able to bond and attach as easily because they haven't had to do that. So what is your task going to be? Your absolute task, if you don't do anything else and if you don't hear anything else, your task is not to treat the behaviors. Your task is to treat the trauma that causes the behaviors. And that is the underpinning of everything that we do at Circle of Friends. And trust me, this is not a popular choice with foster parents because foster parents are trying to take care of kids that are showing some very concerning behaviors. And we all understand that. And part of what we do is to try to support the foster parents. For those of you, and I see a few of you on here who are new to us, if you have a Sunshine Child Welfare client, which are 80% of what we have, are kids in the child welfare system, there is a separate code that you can use. It's called the T1027 code for family consultation and training. What is that code for? That code is for you to sit with the foster parent or the caretaker or whoever has this child and try to say, this is why this child is acting this way. You don't have to use their individual units. You don't have to use their TBOS units. You can use that code to help parents to understand why these kids are acting that way. And I don't know that we're as good as we should be about pointing that out to our new people who come in. That code came into use at the beginning. It's been around for a while, but it's just never been used. And at the beginning of the pandemic, the Sunshine Child Welfare people contacted me, and because we have so many Sunshine clients, and they really wanted us to start using that code. Now, what we have been able to do with that code is to use it very effectively because we don't have to try to wrap it into the child's treatment. It can be entirely separate, and you can just sit with a foster parent for an hour if you need to and say, this is what's happening here. So it's been quite useful. And if you're not familiar with it, just ask your supervisors. So what does it take to be a good child welfare therapist? If you look at this, a lot of it really doesn't have to do with your skill level. Um, we can teach you skill. We can teach you modalities. We can teach you interventions. We can teach you how to do sand tray and everything else. But this is kind of tough work. And the I put it second, but really the biggest thing you have to know is that you're a part of a team here. You are a part of a whole big conglomeration of people that don't get along with each other, simply put. Um, so we have a treatment team for all of our kids that come in. And who's on that treatment team? Sadly, the parent should be first and foremost, but most of the time we don't have the parents. So who else is on the team? You've got the case manager. You've got the case manager supervisor. You often have a guardian ad litem, and they can have some pretty strong opinions about what has to happen here. Uh, you might have a judge. You often might have a lawyer. And they all have opinions about what should happen to these kids. And we all have roles, but it's really easy to forget what your boundaries are. Excuse me. And sadly, what we think we have is often not what we have. We don't have a lot of control over what happens. If the judge says, okay, the kid's going home, the kid's going home. We don't have any control over that. If the judge says, okay, kid, you're going to stay with some cousin in Arkansas that you've never met before, then your job is to help them get ready to go. but it's really important to stay in your lane. And how do you do that? It very simply, do not, please, get on the email and start explaining all of your very passionate opinions about what should happen to this child. Because if you do that, and those of you who have had this happen, please raise your hand, because if you send one email to one case manager, then that case manager is going to send it back to you and she's going to copy her supervisor. And then you're going to answer. And then the next thing you know, there's 25 people on this email chain. You don't know any of them. And you don't know what they're doing with the information. And now they're all fighting behind the scenes because they're all mad at you. So just remember what your role is here. Our role is to guide them on the journey. We don't get to pick the end game. And a lot of times we don't even agree with the end game, and we're going to talk about that. Um, when I say open to play, you're going to, and I know this is hard. I did this before telemedicine. So I realize that some of this has altered with telemedicine, but we're often going to find with these kids that those traditional methods of TFCPT and just sitting there and talking it out is often not going to work in the beginning. So you have all been absolutely fantastic about figuring out how to do telemedicine with play. Those of you who came last year to the telehealth meets play therapy training, we're going to do that one again, because that one had all kinds of applications and interventions and tools and worksheets and all kinds of things that you could use to play with your kids on telemedicine. So you have to be, number one, you've got to be aware of your own stuff. And I kind of skipped over that, but um, these kids can tell you some really hard stuff, and it's really hard if you're not in a good place, if you're having a bad day, if your life isn't going exactly the way you want it to. This can be hard work to do, and I can tell you in the last month, we have lost a couple of people. And we have lost a couple of people, and we have said, go with God, because this is not the right time for you to try this work. It's too hard for you. You're going through some stuff yourself. Um, we had a very lovely therapist who was going through some very difficult things with her child. This is no time for you to try to have transference issues and to try to put those transference and countertransference issues on the side. It's really hard to do that. So if somebody comes to me and says, this isn't the right time, I think I need to step away, I absolutely support people if they say they need to do that. Um, you also, when I say you have to be knowledgeable, this is not for the entry level therapist. It really isn't. Now, we have brought some entry level therapists in. I see Eileen shaking her head. Oh, God, no. We have brought some entry level therapists in, but I have really, really picked them very carefully, because there's a certain something that you can see in people that you say, okay, I think I can take this person who has not done this work, but who has got the right stuff, and I can bring them along. But in general, this is really not a time that you need to learn as you go. I mean, remember, you're hopefully soon you will be back out into homes and schools again. But if you're not, you're doing this on camera, but wherever you are, you're by yourself when you're doing it, aren't you? You're not. You can't pick up the phone and call your supervisor at 7 o'clock at night and say, "Okay, they're all in the living room fighting, and I don't know what to do now." So you really have to be knowledgeable about what you're doing, and you've got to be flexible. When I say flexible, I just mean it's just these cases take such twists and turns. When you're all learning how to do your DAP notes, when you first come, we ask you to put a plan in place, the P section of the DAP note. What are you going to do? So you have the data section, what you did, what happened, what your interventions were, how they reacted to it, and now your plan. You have a plan, and you write, I'm going to do this and this. Next time we're going to work on bubble breathing and affect self-regulation. And then you get there and the whole family has blown up because there's been some crisis in the family, whether it's your kid or another foster kid. you got to be flexible. You got to say, okay, this is what we're going to do today. These cases take a lot of twists and turns. And the last one I obviously wrote before telemedicine, that you can't be squeamish. And there is a certain amount of stuff that goes along with friendly home visiting that we haven't had to deal with for a couple of years. And probably there's a certain amount of us that are relieved that we haven't had to deal with that in the last couple of years. But I can tell you that the things that therapists have called me about saying, I can't go back out to that home. One of them was that there was a cat in the window. Well, there's not a lot of houses that don't have cats in the window. But if you're afraid of cats, then that's not going to be good for you. There was another therapist who called and said, I can't go back there because they have snakes in the apartment. And I said, snakes? And she said, yes. And I said, did you see the snakes? Well, no. Well, how do you know they have snakes? Well, because they told me that they were in another room and they were in a cage, and that's what they did with the snakes, which reminded me of a very long time ago when I was a case manager in Massachusetts, and I went into somebody's apartment and they had a whole room full of cages, one on top of the other on top of the other. One row was for their pet snakes, and the other row was for their pet mice that they were then going to feed to the pet snakes. And they did while I was there. So I learned a long time ago, you can't be squeamish when you're doing this kind of stuff. So if you're a germaphobe, or if you've got any kind of problems going into people's houses, I'm hoping that we will be getting back to that soon. So if you've got some kind of a fear of something, the time is now to recognize it. Now, what else is it going to take? I put all these things up there, but then I pull out the ones that I'm the most interested in. Of course, you have to be empathetic to parents. You may never see these parents, but you've got to be sympathetic to what they have gone through to get where they are right now. Most of our parents are second or third generation. There are very few of them that have not had some of their own stuff before they come to us. For one thing, I look at you and I can see that there's a variety of ages here. But the older you get, the more you're going to realize that these parents are now getting younger and younger, for one thing, and they have had very little caretaking themselves. So most of who we see in the child welfare system have come from generational poverty, generational abuse, generational things that have happened to them where they don't really see any difference in what has happened. Uh, Lisa and I were talking before we started, because there was a very disturbing article in the news this morning, and because it was Florida, I read it, about a couple in Jupiter who had been keeping their adopted child in a box in their garage. They had put a mattress in there or something, but they'd been keeping him in there for years. And he finally ran away, got to the school, told them what happened. Police got there, found the box with the mattress and the light and the whole thing, and the lock from the outside, because once he got in there, he couldn't get out. And he was an adoptive child, and they started doing this the day they adopted him, or very soon after they adopted him. Um, Now, what those articles don't tell you is what happened to those parents to cause them to make a decision so extreme at a very early stage in this child's life, and to not really see any difference in it. And if you look or read underneath any of those articles, you will often find that there's intergenerational stuff there. So trying to just at least understand that these parents were not monsters, that something perhaps happened to them, it will allow you to be better therapists to the kids. It will, because your prejudice, if you will, towards their parents won't come through quite as much. Um, you have to understand the child welfare system. And if you don't, the time is now. And that's why we do a lot of these trainings. You can't work for Circle of Friends if you don't understand the very convoluted child welfare system and the very convoluted judicial system in Florida that works with these cases. I have worked in other states and other judicials that do not do it the way Florida does it. It doesn't mean that it's wrong. It just means that you have to understand what's happening here. You have to understand that when your kids come into care, they almost always have a concurrent case plan. So if I say to you, what is this child's permanency plan? He came into care 2 months ago. What's the permanency plan? Unless it's egregious child abuse, unless they go straight to TPR, termination of parental rights, it's almost always going to be a concurrent plan. Now, what does a concurrent plan mean? That means that for the first 6 months, this kid is either going to go home or this kid is going to go to TPR. What makes that conversion change from one to the other? At the 6 month mark, if they're not moving in the direction of reunification, then the case plan may start to change to um, permanency outside of the home. But you have to understand that when the case manager tells you what the case plan is, and you say, how can you possibly do that? That makes absolutely no sense. It might make no sense from a clinical standpoint, but they're following statute. And statute is what they have to follow. It's what the judge has to follow. It's what the lawyers have to follow. And if you think the therapists understand statute, we do not. So you're going to need to understand that system, and you've got to communicate with your team. And when I say this is optional, it seems to be optional for them. I mean, they don't call us back half the time, and we know that. You know, we're trying to call case managers, we're trying to reach them, we're trying to reach out to them, we're trying to get information from them. Are they answering us? Not always, but what's happened in the last 2 years? I mean, think about this. For those of you who've been around for a while, in the last 2 years, all of these case managers have gone home to work. All of these case managers are more than likely younger people with children of their own. They've had to do the homeschooling thing. They've had to try to manage their kids at home. I don't know if you've had this experience, but I certainly have, where I would call one of them and they would start to talk to me, and all of a sudden you'd hear some screeching in the background because their kid fell off the couch and now the kid is screaming and they're trying to take care of their child and they're trying to talk to me. So be patient with them right now. We're coming out of a very, very difficult time, but you have to be able to talk to them, and you have to be able to reach out to them. And sometimes texting is better. Sometimes I get the text better, but try to reach out to them. It's really not optional. Um, and when I say you need to conceptualize the case, you're going to have to make your clinical decisions based on a whole lot of levels that you wouldn't have to do if you were sitting in a clinic and a mother brought the child into you and said, you know, he's just acting up in school. You're going to have to, and we're going to talk about assessment, you're going to have to look at a whole lot of levels here when you're trying to figure your case out. And lastly, and this is Lisa's big thing, you have to take care of yourself. It is, and I would ask any of you who have any opinions about this, but how has your work changed since the pandemic? Your work has changed a lot since the pandemic. I mean, for one thing, how are you doing your work now? You're not getting in the car and driving, which may have taken up your time, but what did you do when you were sitting in the car driving 20 minutes from one client to another? You might have put the radio on, you might have listened to some of your favorite songs. Now you're not doing that. You're sitting in front of your camera the same way you are right now, and you're seeing your client and you're clicking off, and then you're waiting a few minutes and you're clicking on to the next one. And then what happens at the end of your day? Do you get in the car and get to drive home and get to listen to some music? Maybe you listen to the news. Maybe you get on the phone and talk to your friend, and then you're ready to transition back into your house. There's no transition time now. You're just there. So you get done, you walk out into the kitchen, and your kids are saying, "What's for dinner, Mom?" So it's a very different time. You got to take care of yourself. Have any of you experienced any of that since you went to all telemedicine? Eileen?
I don't have kids, but I have pets.
And they're waiting.
So
They're waiting
They're
for you.
waiting for their food. Or they're waiting for me to give them attention. Or, they'll try and jump in the middle of session.
Well, we've certainly seen that. We saw
Yeah.
that yesterday, didn't you? Don't you have a red cat? Was that your cat that was jumping on you yesterday?
Probably I have two cats and two dogs. So the dogs will bark, the cats will jump on the desk. Because I can't close the door, otherwise they'll be meowing. And I didn't realize how loud it was um, for the client until I had a client say, "Do you have a cat? It's meowing." I was like, "Yes."
Yeah, yeah. It's a little hard to keep that illusion of professionalism when your cat is crawling on you, or when. Well, we've kind of got you. You guys have all gotten a lot better about this since we started doing this, because right now I don't see anything terribly funky behind any of you. But a lot of times when we first started this, we had the whole issue where we had to sit with our therapist and say, "Okay, you guys, if you're going to be in your bedroom, the bed's got to be made. I don't want to see the cat crawling on your counter. You have to be dressed, at least from the waist up. And if you're not dressed from the waist down, for God's sakes, don't stand up." So it was a whole bunch of stuff that we had to do. Um, but learning how to balance your work life balance when there is no work life balance, you're sitting right in your work life, is something that you're going to have to do. That just adds to everything else that we're talking about today. Which, as an aside, I would have to say that you guys probably need to give yourself more credit than perhaps you have given yourself, because nobody expected this to happen. Nobody expected us to get thrown into the last 2 years. And yet, I would have to say, I have seen some absolutely unbelievable efforts on the parts of our therapists to do all the things that I'm talking about right now and still balance themselves. So um, I don't know who was here, Carol, for your Christmas party. I know Eileen was. Eileen came in a costume, so I remember that. Um, but Carol, just tell them a little bit about what you did for everybody at Christmas time. It was all we could do, but what we did turned out okay.
Oh, wow, that's been a while ago. I just put together a PowerPoint and just kind of highlighted all the different things that happened in 2021, with the pandemic, with the main office for Circle of Friends moving from one location to another. We played trivia, we played Jeopardy, that were all, the trivia game was based on what you heard in the PowerPoint, and the Jeopardy game had to do with different types things in therapy, and it was just fun. We showed pictures. We had an open house in Bradenton in July, and which was a lot of fun. It was nice, everybody in person, seeing each other. We all wore masks, and I think we had a really good time. Had some good time to create some good bonding. I know Eileen, you were there, and I think you were smiling a lot, and I think you really enjoyed being there. And it was
Yeah,
nice having people in the
the open
office.
house. Yeah, the open house was nice. It was fun. And it's good because with COVID, we're all just at home on our computers. So I'm a people person. I like being around people. And so one of the challenges is one, doing telehealth because I feel like I'm more effective in person. Um, and being able to go to my coworker's office next door and say, "Hey, what do you think of this?" or "I'm struggling with this," but that's there. Those are little things, and I've adjusted to them. So, I mean, we have a great team. So I'm glad that Carol and Barbara and everybody's just a phone call or a text away or an email.
Well,
Try.
and again, and thank you for sharing that. I think what's happened to all of us is that we wouldn't be if we weren't social, we wouldn't be in this field. If we weren't social beings, we would be accountants or we would be librarians and we would be in the research field, but we aren't. So we've really had to find out ways to kind of offset that. And that is part of self-care. And Carol set that open house up for the Bradenton office, and we did it at the end of July. And we did have a lot of fun. We took a lot of videos. People did demonstrations. We had food. And here's the way this whole pandemic has gone. Everybody went away. Everybody was happy. And then we discovered that one of the people that was there had COVID the day he was there. He didn't know it because he hadn't been symptomatic. So then it kind of threw everybody into a tailspin. Everybody was all set to start coming back to Carol's beautiful office, and everybody just got completely thrown. And that's the way the 2 years have gone. So long, short way of saying you guys have done a great job. And I think this slide is in the wrong place, but I will do it anyway. When we're talking about treatment modalities, there's a whole big stuff going on right now in the child welfare community. And I will just share this with you because it's annoying me, that child welfare for years has wanted us to do evidence-based treatments. And what are evidence-based treatments? TFCPT is an evidence-based treatment. It's been around for a long time. It's been studied for a long time. But they have wanted us to do certain evidence-based treatments, and they have picked them out. And they are not ones that I would typically use. So we do a lot of different things at Circle of Friends. Those of you who are new to us will see that. We do a lot of different training. One of the ones we have set up for this year is the expressive therapies, which is all kinds of play therapy. It's play art, it's sand tray, it's role play, it's yoga, it's all kinds of things. Because when you start this work, when we get into the treatment protocol, you're going to see that you cannot start out with talk. It's just not going to work. But we use all of those modalities. We use, of course, all the parent-child relationship ones. We use TFCPT. And increasingly, that last little line there, that last little bullet point, increasingly we are seeing a lot of people getting specialized training. Several people have done the EMDR route. EMDR is a wonderful technique for use with trauma. I put brain spotting in there, and I always say I've sat through 6 hours of brain spotting and I still don't know what it is. It's very complicated. Hypnosis is the only thing in Florida that you do have to be certified for. You cannot do hypnosis just going to a training. The emotional freedom technique is that technique that it's tapping. And when we talk about tapping on your acupuncture points and saying everything is going to be okay, which sounds kind of silly and gimmicky, for whatever reason, it seems to make people happy and it works. And if it works, it works. An internal family systems therapy, once again, I will say that I have sat through hours of trying to figure out what this guy is talking about with your parts, and I don't understand it. However, if you do, everybody picks out what they're good at. It's not going to work if you don't feel like you're good at it and you're not comfortable with it. All I'm going to say about this slide is that a lot of different things work. So don't feel that you have to use one thing because somebody's telling you do. Do the thing that you feel good about. Do the thing that you feel that you're going to be effective. And don't let anybody tell you that it's got to be just one thing, because it doesn't. So let's go through the core competencies, and then we'll probably take a break, which is why I was checking the clock. What do you need to treat child welfare clients? And when I go over this, I don't want you to think this is so much, because we train in all this. The reason we have a training calendar set up the way it is so that you have a chance to get all of this stuff in the course of the year. You also have that chance to talk about these things during your group supervision. We have three specialty groups set up right now. Our sexual trauma team, our adoptive team, and our intensive treatment program, which is for older foster youth. We have meetings specifically to those teams where we really tease out these cases and really take a deep dive into them and say, where should we be going with these? But all of this wraps into all the stuff we're going to talk about right now. You absolutely have to understand the neuroscience of trauma. And by that, I mean you have to understand what has happened to this kid's brain while he is developing or she is developing as a young child when that kid has been repeatedly traumatized. And anything that we've done here in training, we've shown you the brain scans, we've shown you the CAT scans. It is not um, it is not just clinical theory. We've certainly heard follow the science enough in the last couple of years, but you definitely can follow the science with this because this technology, this study goes back now probably 25, 30 years, that we know that kids who are traumatized or uncared for or abused in the first several years of their life, usually the first 3 years of their life, are going to develop differently. Their brains are going to develop differently. There are going to be deficits in the way areas of the brains are developed. This is important for you as therapists trying to work with these kids. It's important for you to help foster parents understand. And it's absolutely important for you to help the adoptive parents to understand this when they are trying to work with these kids. So we're looking at the impact of trauma. We talk a lot when we're staffing about what has happened to this kid who's now 16 in the first, or 14 or 12. What happened to this kid in the first 3 years of life to affect his current functioning? So we always look at that. We talk about attachment and bonding, and we do a lot of training on attachment and bonding, and those are not just words. When you have been neglected, when you have not developed those portions of your brain that you need to understand that there's another person out there who's going to connect and take care of you, those are absolutely functionings in the brain that don't get developed if nobody's taking care of you. So what you have is a child who ends up with disordered attachment. That is not reactive attachment disorder. Every kid in the child welfare system has got disordered attachment, which means that they have had interruptions in their ability to learn how to attach and bond. Any kid that you have, whether it's a foster kid, whether it's a kid in a group home, all of these kids have got attachment issues. Uh, the things that we have done historically with kids in foster care have made those things worse. Because if you think about the foster care system, and I can't speak so much to the group care system because I know that the group care system is going through some pretty big changes right now. But what happens in our foster care system is that we put kids in care, and if we don't support those foster parents, if we don't spend the time that we need to take care of these foster parents, they're going to call and say, get this kid out of here. So then what happens is that you have kids, and we've gone through this in other trainings, where they then go into the foster care system and they bounce from place to place to place, which further impacts their ability to attach and bond because they don't trust anybody. For those of you who've sat through the adoption training, and we watched a lot of those videos of those kids who talked about what it was like for them in foster care and how many times they moved and how they would come home and the stuff would be in the bag and they were getting ready to go and nobody would talk to them. All of that affects your ability. So you have to understand all of this stuff. You've got to understand what has happened to this kid and how it has affected him neurologically. We absolutely need to understand addiction in a way that we maybe didn't have to 20 years ago. When I first got into this field as a treating professional I'm guessing it was probably like late 80s when I started the first private practice I had. At that point, we had heroin and we had cocaine. We didn't even have crack at that point. I mean, think of how we have evolved over the years. We didn't have opioid addictions to the extent that we do now. There was the occasional person that hurt their back and got hooked on drugs, but not the way it is now. If any of you have had any kind of an injury in the last couple of years, if you have broken a bone or in my case, I had a ruptured appendix a few years ago. It's very easy to get those drugs now. is extremely easy to get those drugs. And I can remember going to the pharmacy to pick up the whatever it was, hydro. I can't even remember what the name of it was. But the pharmacist came over and said to me, "Do you understand what this drug is? And do you understand how to use it? And do you understand that if it's every 4 hours, don't take it at 3 hours? Because if you take it at 3 hours, the next time you're going to want it at 2 hours. And you can't do that." I'll tell you, I took the drug home and threw it away because I thought this is really too much. I can't deal with this. But we have to understand as treating professionals what has happened, the impact of addiction and abuse and neglect on everybody, but most especially our kids. So if our kids come in to the foster home setting and the first thing they do is try to break something or damage something in the home or do something to upset the foster parent, one of the things that we've tried to do, especially with our intensive treatment program, is to immediately get to those foster parents and say, this is what's happening here. I'm here to support you, but this is what is happening. This kid is frightened. This kid is scared of you. This kid thinks that if he does something that you will throw him away, and you will. So we really have to understand that. The very first kid that we got in the intensive treatment program was 15 when we got him, and he had had 163 placement disruptions when we got him, and had extremely impaired ability to attach. Now, what's the end result for that kid? That we had that kid. We worked with that kid for 2 years. He got moved a lot, but we were able to stay with him because of telemedicine. So we did establish one consistent treating person in that kid's life. Where he is now, because of course, they move them and then you lose track of them. I am not sure. I don't think the bets were going to be too good for him, but we certainly could see when we saw his record and saw all the disruptions, all the removals, all the Baker Acts, all the elopements, that this was a kid who had very severe impact of abuse and neglect. When I say certification as a trauma professional, we do this training once a year for those of you who would like to become certified clinical trauma professionals. The CCTP that some of us have after our names stands for Certified Clinical Trauma Professional. This is a training. It's a 2-day training. I believe, I'm not sure, Carol, I think we put it on we usually put it on at the end of the year, so we might have put it on in October or November. I'm not sure. But we always do it. Can you
September.
Wow, we put it in September? Oh, good.
Mm-hmm.
It's really a really good training, and we use Eric Gentry and Richard Roten, and they're international trainers in trauma. But that certification goes through the 10 core principles of working with trauma treatment. They go through 5 different ways to do the trauma narrative. It's a really in-depth training. So if you're interested in that, we will be doing that. Well, I didn't realize it was September, but we'll be doing it in September. And lastly, you really have to have the adoption competency training. So if you haven't gone through it, we will be setting it up as soon as we have. Well, I don't like to wait till I've got 5 or 6 new people that need it, and I'm looking at a few of you that I think do need it, and then we will set it up. Adoption competency is absolutely critical for your work with this population, because you've got to understand. You have to understand the problems with interrupted bonding, for one thing. You've got to understand what's happened to these kids before they get to the adoptive home. But then you have to understand all of the things that happen with adoption. Adoption is not an easy thing. And we do the adoption competency. Carol's a trainer, I'm a trainer. And we usually do it over 5 Thursdays so that you don't have to give up your whole week. But it's good for 32 training hours too, so it's not a bad deal, but it's a really helpful training. So when we look at the special challenges of working with the child welfare clients, we know that these kids are going to behave badly. We know that they're going to come in and they're going to do things because they are expecting you to turn against them. It's just, how many kids have you seen that have walked into a very calm, structured foster home and created their own chaos within the first hour that they're there, because that's all they know. So we have to understand that. We've got to work with our teams. And when I say it's not easy, if any of you have had to go to a multidisciplinary team, you know what I'm talking about. That they're all going to look at you and want you to tell them what to do, as long as it's what they want you to tell them what to do. And if you're telling them something that they don't want to hear, then they don't want to hear it at all. But being a member of a team when you're a therapist has a special place. So I know Eileen has gone to these meetings. I know Carol has. Dylan probably has. I'm looking at Alexa. You have had to have gone to them at FOMS. And nobody wants you to say anything other than what they want you to say. So for the fact that they always say, well, what does the therapist think? And well, the therapist can make that decision. Or should the kid have unsupervised visits? Let's ask the therapist. Should the kid go home? Let's ask the therapist. Well, then the therapist says what they think, and everybody hates you because it's not what they want you to say. So it's don't get heady is all I'm saying when you first go to these meetings, because they will ask you what you think, and you're going to tell them what you think, and they're going to say, oh, that's ridiculous, you're stupid. So it can be difficult, because everybody just wants you to do what they want you to do. And think about this. None of these people have the background that you're coming from. Case management is dealing with statute. GALs are dealing with what they think is their role, which seems to be sometimes misunderstood. Foster parents, attorneys, they all have their own ideas. We have had a lot of cases, and I think Carol can speak to this with the ARCs that she's been going to. Carol's on an administrative review committee for adoptions, and this is a review committee for disputed adoptions. So if there are more than one party that wants to adopt this kid, the ARC review team is going to review and make a recommendation. What we have seen very often is that foster parents may decide that they would like to adopt. And then you have a family member that comes forward and says, well, I think we would like to adopt and keep this child in our family. And then you have all kinds of differing opinions, and things don't always end well. All the ones that I have been involved with, and Carol's are a bit different, but any of the ones that I've been involved with have involved grandparents that have come from other states and have said, wait a minute, these are my grandchildren. I want to adopt them. I'll take care of them. I'm going to keep them in the family. And we as clinicians think, family is best, and this would be the best thing. But then you have a foster parent who said, well, wait a minute, I've had this kid for 3 years, and I want to adopt this child, and it would be very disruptive to move this child out of my home when this child is bonded in this home. What do you do? I mean, those are very difficult decisions to make. And I guarantee you that if you are the therapist in that meeting, they're going to say, what does the therapist think? And then the therapist is going to say what he or she thinks, and then everybody's going to be mad at that therapist. And I'll use Carol's example because it was a long time ago. But Carol, you remember being called into court for the family. They wanted to split up the siblings. And I think there were 2 girls, and then there was the brother who was acting up. So nobody wanted the brother. And the 2 little girls were in the separate home. And Carol was asked, I forget how they asked the question, but you answered the question and everybody got mad at you. I think that the question was, would it harm, how did he put it? Would it harm them to be separated?
I think it was more like, is there any safety concern if they were together? And that was not even what was even talked with me ahead of time. Plus,
Right.
it was the second time I was in court, like 2 weeks, like 1 week apart.
Right.
And no one talked to me in between time. So I had no idea where they were going. But the boy was not a safety issue to his sisters.
Right.
So I had to answer it truthfully. and got thrown under the bus.
Well, and that's the other thing. For those of you who are new to us, you will get subpoenaed to court. Our therapists get pulled into court all the time. Since the pandemic happened, they've been doing it virtually. And don't panic because you do get paid for it. We have worked that out over the years. But when you go to court, I mean, look at those people on that team. Every one of them comes from a different focus. The foster parents have one idea, the attorneys have another idea. Attorneys speak an entirely different language than we do. So if they don't prepare you before you go on the witness stand, if they don't say, this is what I'm trying to find out, as in Carol's case, they asked her cold and she answered the question, and then it wasn't what they wanted to hear, and it was a big hullabaloo, and we had to have, of course, a big meeting about it. And I can remember it was Youth and Family Alternatives at the time, that the executive director of Youth and Family Alternatives said to the attorneys, if you didn't prepare her, then don't blame her for what she said. So that was kind of the end of it. But yeah, everybody's got a different idea. So these teams can be difficult, which is why this little picture is here, that we do end up butting heads with each other. We don't usually have any parents to work with. When we talk about getting into the assessment section, let me just jump ahead so I can see where we're going to take a break, if you guys don't mind. Okay. Let's finish the special challenges and then we'll take a little break. The challenges of working with these kids is that usually we just don't have a lot of information. We have to fill in a lot of blanks with these folks. And the other thing that I think we do see is that we don't always get accurate information. If there's one thing that the biological mom is going to lie about, and she's going to lie about it to protect herself, is what she did while she was pregnant. A lot of these folks, and you know from looking at the histories of a lot of these people, they didn't even know a lot of these women didn't know they were pregnant. A lot of these women, when we try to get the family history, you might have 4 kids and 3 different fathers. You don't have they're not going to be accurate reporters. Either they're not going to remember, they're not going to know that they were pregnant, they're going to pretend that they weren't using. You're going to have to really kind of look for clues when you're trying to look with these clients. If you get the CBHA, you can at least get a little bit of family history. I think that's really all CBHAs are really good for. And I say that with irony because we do them and we take the money for doing them. But really what you get is family history. And it may or may not be accurate. So you may or may not have all the right information. You're often going to have to make an educated guess about whether or not there was drug involvement during pregnancy. That's why we changed on our in-depth assessment, which is the assessment for the under 6s. We changed the drop downs. Was the mother using drugs from yes or no to yes, no, or suspected? And there's several yes, no's, or suspecteds in there. So, and it's okay for you to say suspected. This isn't a forensic document. Nobody's going to say that you were lying or being unethical. If you know in the history that this mom had gotten into opioids when she was 16, and that this mom has been using drugs, now she's 25, and in the CBHA, she says, I didn't do anything while I was pregnant. Well, what are the chances of that? You know they're not good. If she was drinking before the pregnancy, she didn't stop drinking while she was pregnant, or she didn't even know she was pregnant. So we have to fill in the blanks with a lot of this stuff. We just don't have a lot of good information. And that's another difference than if you're working in a private clinic where you've got a parent coming in and saying, this is what's going on with my child. You're filling in all kinds of holes here, trying to figure out what's going on. The case that we staffed yesterday, Eileen, you were in that staffing, that Bonnie was presenting, the case that she was presenting, she's got all kinds of holes in that story. I mean, she's got probably 10% of the story has been told. And the rest of it, we're all looking at it going, huh? That doesn't make any sense. So then it's an incest case. So then you're trying to say, okay, was there intergenerational incest? Well, no. Well, why is this family being so vague about it? Well, they're being vague about it because they're trying to hide something. So, and you're not making those assumptions because you're being mean. You're making those assumptions because that is really the reality of it. And as Bonnie was trying to say, well, I don't know what to do with this. I think we were trying to say to her, you don't know what to do with it because probably nobody's telling you the truth. So, and how many cases are you going to have in therapy where everybody's going to be lying to you? If you're going to work here, you're going to probably have a lot of them.
Yeah, that's true.
I think you're going to find that you're going to just have to make educated guesses about a lot of these kids. Alexis is joining us from FUMSH. I have spent plenty of time over the last 20 years at FUMSH, and trying to make educated guesses about some of these kids that come in, despite the best efforts that admissions department makes to get information about these kids, to get CBHAs, to get psychological reports. Where is this information coming from? It's coming from the parents, who are more than likely not going to say, yeah, I was drinking when I was pregnant, and I was drinking my brains out, and didn't know I was pregnant, and then he was born with alcohol in the amniotic fluid. I had a couple of those. So you're not going to get a lot of good information. So you're going to have to try to work through some of that. And finally, we have the whole issue that we've talked about before, that one of the other challenges of working with this population is that we do not get to pick the end game. Who does get to pick the end game? Judges. And very often, I haven't heard a lot about the judges on the West Coast in the last couple of years. Maybe COVID has calmed them all down. I don't know. Because for a while, some of the decisions that were coming out of the judges in the West Coast were just totally bonkers. Um, I don't hear quite as much about, like, Orlando, Seminole. I just don't hear as much about those decisions being sort of crazy. In fact, I don't even know who the judges are on the West Coast right now, which means that they're not as controversial as the ones before. But what would happen is that they would make decisions, now probably in good faith, of course, but the decisions that they would make would be counterproductive to our vision of their treatment. And the one that comes up the most, because we do visitation, is that the judge court orders, quotes, visitation with a previously violent parent, or the judge court orders visitation with the child and the dad who sexually abused her. So we get a lot of that kind of thing. And I can tell you that if the case manager calls you and says, but this is court ordered, who is court ordered? You're not. The court order is the one that is given to the case manager, and it's her job to then, however stupid or ill-advised it is, it's her job to meet that requirement. But you are not court ordered to do anything. So I say that because that trap happens a lot, is that a lot of times the case managers get frustrated and they'll say, but it's court ordered, you have to do it. You are not court ordered to do anything. And I can tell you that what Angie brings it to me a lot with the visitation cases, because some of them are totally wacky. And I will say, okay, this is how we're going to approach the case manager. And we're going to say, well, the one we were just talking about the other day is the best example, that it was a termination of parental rights. It was a mother who lived in Kissimmee. She hadn't seen her kids for a couple of years. She had two boys that were in two separate placements way down in South Florida someplace. One was 3, so he had been removed very early on. The other one was 11. They were in separate homes. She went to court, and her final wish before the termination of parental rights was that she could watch her children play together for an hour. Now, these kids didn't even know each other. The 3-year-old didn't know the 11-year-old. The 11-year-old didn't know the 3-year-old. The 11-year-old knew a whole lot more about the mother than the 3-year-old. And the judge did actually order this, that he thought that it would be a good idea if everybody came to the Kissimmee office and they sat in our play therapy room and played together for an hour. And I think what happened, it was right around the time that COVID slammed us all down on March 18th of 2020. We were right in the middle of trying to say, I don't think this is such a great idea. And the case manager kept saying, but it's court ordered. Those kinds of requests come in a lot. And I think judges do them because they don't know what else. I think sometimes they just don't know what else to do with those final visits. But that can be a challenge. And you all need to understand that you're not court ordered to do anything. So don't let them throw that at you. And I don't say that cavalierly, because I know that the case managers have a lot of stress on them. But we can't do something that we don't think is in the best interest of our client. So then our job becomes to try to explain all of that, to try to explain why we don't think this is a good thing. And we've talked about this a little bit ago. The other problem is that everybody wants the therapist to make the decisions. Everybody wants you to say the child should go home, the child shouldn't go home, the child should have visits, no visits, supervised visits, visits with the dad, visits with the mom. And that isn't your job. And you can, and I can tell you,
You
if
know
you
what I've noticed too? That a lot of times they want you to answer these questions and make these decisions when you've only met the kid like a few times.
Sure, absolutely, you should know how to do that. Yeah, and Stephen's right. And sometimes I think that's the only reason they get you on the case, so that you can make some of these decisions. You have been, as therapists, have been asked to go in and tell kids that their parents have committed suicide. You have been asked, our therapists have been asked to go in and tell kids that they are not going home, or they're not going back to the foster home that they thought was going to adopt them. That is not your job. And can you support the child with that terrible news? Yes. But everybody seems to think that this should come from you. And it shouldn't. For those of you who are new and haven't had to face this yet, if anybody asks you to do anything that you are uncomfortable with, you only have to call one of us and say, what do you think we should do here? Because we don't just say no to the case managers or the judges or the attorneys. We have to I always say, we have to give the appearance of cooperation, even if we're not going to cooperate, because these people are our customers. And if we keep saying, no, we're not doing that, they stop becoming our customers. But the flip side of that is that you can't do something that's going to be harmful to a child. So, and finally, anytime, anything you say, they're going to get mad at anyway. Carol's a good example of that with her little hearing in court that day. So this is challenging. It's very challenging work. I am going to, what time is it? Oh my gosh, it's much later than I thought. I'm sorry, you guys. One of you should have said to me, Barbara, stop talking. Okay, it's 25 after. We'll get into treatment protocol, come back at 25 of. How does that work for everybody? Let us look at how we conceptualize what you all need to be doing with your clients. Now, I'm not saying that this always has to happen in exactly this order, but we've really looked a lot over the years at how we effectively work with kids who come into our system, who don't feel safe, who are usually in a state of high anxiety or trauma. We can't sit down and start to have a little chat with them. And especially now, because we are doing so much with telemedicine, it's even more complicated. When I tell you that we are going to be doing the CCTP certification, wait a minute, hold on. If you haven't done that, I'd really encourage you to do it. It is, we do it over a 2-day period. I think we have it scheduled maybe for 2 Thursdays in a row. I think we tried to stretch it out a little bit. Is it 2 Thursdays? Okay. And it's a pretty intense training. I've sat through it now probably 3 times. But a lot of what we eventually tried to set up as these 4 steps, we really took out of the CCTP overlay. So what we look at is really 4 steps when you're working with these clients. Your first step is going to be your assessment. And what are you assessing? You are assessing your client's level of safety and what kind of traumatic situations they are reacting to. So step 1 is really assessing safety. And the assessment, I know we give you 20 days to do the assessment, and Medicaid gives you 30 days to do the assessment, and we get them in on time because that's what we have to do in order to get paid. But as we go through this, I think you're going to see that we leave our assessments fairly fluid because you're going to learn things about your clients as you go along that you didn't know. And you have to be able to kind of adjust what you're doing as you go along. So there's a difference between how you need to do it for the needs of your clients and keeping Medicaid happy. We keep Medicaid happy so we get paid, but we're going to look at assessment as a fluid situation that you may add things to as you go along. Once you have your client feeling safe and somewhat deactivated with you, you're going to do some psychoeducation about trauma. You're going to really teach regulation. Now, doesn't this really look like TFCPT? It kind of, in a way, is. The third thing you're going to do is do your trauma processing. And we're going to talk about trauma processing is not necessarily sitting them down and saying, tell me your story, kid. But we're going to look at psychoeducation. We're going to look at trauma processing. And then we're going to look at how we terminate. So those are kind of our 4 steps. Hold on. So what happens in the assessment stage? You can do anything you want. You can do TFCPT, you can do motivational interviewing, you can do basket weaving, you can do anything you want. But if you do not have a good therapeutic relationship, it's not going to matter anyway. So we certainly know that we like to think that we've learned all these things, we've gotten all these certifications, we've got all these initials after our name, and we think we know what we're doing. But if we don't know how to develop a relationship with our clients, it's not going to matter. The most important thing is not what you do, but how you do it and how your client responds to it. So for those of you who are kind of new to the field and you think, oh gosh, I'm not EMDR trained and I don't have this and I don't have that, you got yourself. You've got yourself. You've got your resting face, which hopefully is happy and cheerful and caring. And a resting face is kind of something you have to develop over time, isn't it? Because you can't be glaring at your clients because you're thinking about what you're going to make for dinner. You've got to be able to develop a relationship. And for that, you just need yourself. You just need your good, kind self. And that's why you're in this field. We also have to help our client feel safe. And then we're going to develop a trauma assessment that's going to help us set up a treatment plan. Now, when I say safety, and those of you who have been with Circle of Friends for a while know that the first thing, I don't care what's happened to this kid or how many times it's happened or how many times he's been moved, at the back of your mind, what are you doing when you first start working with this kid? You are helping that kid feel safe. And if you think these kids feel unsafe, oh yeah, they do. So they may be brittle with you, they may be argumentative, they may refuse to talk to you, they may be silly, but all of it comes from the fact that they don't feel very safe. So when we talk about some of the things that we do, we talk about Sandtray, we talk about art, we talk about some of the telemedicine techniques. What you're really doing is helping them to feel that they're in a safe place with you. And over the years, I have had more than one foster parent say to me, all you did was play with him. And if you think you're not going to hear that in your career, you are going to hear that in your career. All you did was play with him. Well, why did you play with him? Why did you sit on the floor and play with him? You wanted him to feel safe. So do you think foster parents always like that? No, they don't, because they want you to do something. And I've had that from judges. I've had it from GALs. So what do you do? How do you explain what you did? I mean, what's your go-to line when they say all you did was play with them?
Well, I was going to go back to the safety thing that you mentioned. I have two teenagers who were removed. This is the second time, but this time they're in a foster home, and the foster parent's amazing. I love her. Um, but one of the girls has anger issues and has gotten in trouble at school for fighting. And last week we had talked about, what do you think is going to happen if you get in trouble at school for fighting or hitting somebody and they call your foster mom? And one of the things she said, I'm worried that she's going to kick me out. So I'm really trying really hard not to blow up at school. I'm like, well, she's treating you like her daughter. Do you think she's really going to kick you out? She's treating you that way? It's like, well, I don't know. So I brought that up to the foster parent, make sure, that if there's any issues that we're going to try and work as a team to resolve them. And, but that was her initial reaction because grandma gave up on her.
Sure.
Mom, let her be sexually abused, so.
All of our kids have these god awful stories. They do. And, when I first start doing supervision with somebody and I say, well, what's this kid's story? You used to have this therapist who's an older guy. Well, I'm an older gal, so I get that. But I would say, okay, Miles, what happened to this kid? Well, he was abused. Okay, Miles, you're working for a child welfare clinical agency. What happened? He was abused. Okay, was he burned? Was he beaten? Did somebody throw him off a bridge? I mean, what happened? Because understanding what happened and when it happened and how many times it happened and how old they were when it happened is all part of fleshing all this out. And when you do, it's like Eileen said, if your grandma gave up on you and your mother let you be sold into sex slavery, why should you think that a foster parent is going to keep you? Why would you? You don't have any frame of reference for that. So if we don't understand that, that's really what we're doing in the beginning. We're just helping them to feel safe. And because we have a lot of little kids, sometimes when we really get down to it and say, well, how are you going to make them feel safe? Some of the treatment plans that we have written for little kids are fairly specific in the beginning. Like, what are we going to do to make this kid who was sexually abused by his father in the bathroom? How are we going to make him feel safe? Well, he's not going to feel safe in the bathroom. So what is our objective for one of these kids was that before he went into the bathroom, the foster mother would always check the bathroom and make sure there was nobody else in the bathroom. He was abused at night in the bed. So he said, I would feel safe if you checked the closet for monsters. He was a little kid. So every night, this foster mom, again, a real saint, would go in and check and say, there's nothing in here, everything's fine. And she'd show the flashlight and say, everything's okay. The second thing he wanted was there was a story that he wanted her to read. And she would read that story, and then he would eventually be able to go to sleep. But that's what we put in the treatment plan. We put that she would check the closet for monsters and that she would read, I forget what even story it was. And that was what he wanted. And when he eventually began to say, okay, I'm not scared anymore, then we moved on to other things. So depending on the age of your kid, it depends. Like with Eileen's kid, you can sit and have a conversation. She's a teenager. With a little kid, you have to find something that makes them feel safe. Maybe it's a teddy bear. Maybe it's a comfort object that they want to take with them. Doesn't matter as long as they're feeling safe.
Sometimes it's just you, the therapist.
Yeah, yeah, it is. It is. As I said, you've got yourself. If you got nothing else to work with, you've got yourself, and don't underestimate yourself. You've got it. You wouldn't be in this field if you wanted to be a research librarian. So, what are we looking for in the assessment? I know that you've got that biopsych that you have to fill out. It only pays you $35. I know it's a big, long thing. I will tell you that we have made that a lot shorter. When we went to the Bio 3.0, we took a whole bunch of stuff out of that. And really, the Bio 3.0 is just a smokescreen for us to put in those 2 questions about gender identification or gender orientation and sexual identity. So don't skip them, because a lot of people seem to skip over them. That's why we redid the bio, so that you can, unlike apparently DeSantis, you can now say to your kids, well, how do you identify? What are your pronouns? Who are you attracted to? And maybe they're going to say, I don't want to talk about that. Or maybe they're going to look at you and say, I don't know what you're talking about. But what are those 2 questions doing for you? They're allowing you to say to your client, I am open to having this discussion, even if they don't want to talk about it right now. So, so we're really going to look at all of that. We're going to, when you begin to do your assessment, you might be able to get this from the CBHA, but what you really, really need to look at is prenatal history. You need to see if you can get any indication, and the CBHA is about the only place you're going to get it really, are risky behaviors, pre-pregnancy behaviors, pre-pregnancy drinking. Maybe when did mom find out she was pregnant? A lot of people don't know that they're pregnant until they're past their first trimester. And with you got to remember, a lot of these folks, for those of you who have had babies, usually if it's a wanted situation, you're waiting to find out that you're pregnant. You're excited about it. You're going to the doctor. You're making sure that you're eating right and taking those vitamins and all of that stuff. This is a different way of looking at pregnancy. For a lot of these women, pregnancy was not a wanted thing. For a lot of these women, pregnancy came out of risky behaviors or somebody that they don't even know or don't care about. So having some idea about what the pregnancy experience was like is important for you. But why is it important for you? What's that going to mean for your kids? What are we really looking for here with the prenatal history?
I'm always looking for, to see if there's any issues that affected the pregnancy, whether it's stress because of TV or homelessness, nutrition, substance use.
I'm so glad you said that, because that the whole what was the thing that went around a few years ago about playing Mozart to your tummy or whatever, and a lot of people say, oh, that's bunk, and but it does. The baby is going to be affected from the time the baby is conceived. So we want to know what that pregnancy was like. The thing that I ask you all to look for, and hopefully you won't find it, is fetal alcohol. In our employee manual, if you go way to the end where we have some of the assessment tools, there is an assessment tool for fetal alcohol. And there's some pictures in there of some of the facial things that you might look for, with the widespread eyes and the flat nose and I forget what this is called, being flat. But not all kids who are affected by alcohol have got the facial features. The facial features come at a certain point in the pregnancy, but some kids don't have that. Some kids just have parents that were drinking. And depending on that, what we see with fetal alcohol with a lot of these kids is that it's not that they're so far gone that they can't be successful. Of course they can. But with fetal alcohol, there's not a lot of understanding of cause and effect. So kids that have fetal alcohol don't understand that if I put my hand on the stove, I'm going to get burned. There's just not a lot of understanding of cause and effect, which can make them look like they're developmentally delayed, or can just make them look like they're acting up, because I've told you 100 times not to put your hand on the stove, and yet you put your hand on the stove. So it's something that we always have to look for, because almost all of these pregnancies are risky. Almost all of them have had a lack of prenatal care, risky behaviors during the pregnancy, all of which affects the baby. Second thing we're going to look for is what happened in the first 3 years of life. And I don't care how old the kid is when they come in. Look at what happened in the first 3 years of life. what might you be looking for as red flags in that kid's first 3 years of life? I'm looking at Eileen was just talking about having two teenagers. I mean, what happened to those kids in the first 3 to 5 years of their life? More than likely, they didn't just wake up at 16 and find out that they were in a bad situation.
No, no. I think they were in a bad situation before when they were little, even though they don't seem to recollect a lot of what happened when they were little. His mom had numerous boyfriends. There was TV going on. I don't think this mom has substance use issues, but the case closed, permanent guardianship with grandma, and the kids were placed with grandma, and grandma has other kids, like other cousins and stuff. So, and I was doing like a genogram kind of historical family thing with the girls, and mom grew up with her grandmother, so with the girl's great grandmother until she was 12, because that's when that grandmother died. And then she came to live with her grandma, and she didn't know she had brothers. And all of her siblings have been incarcerated for either DV, for substance, or for murder, attempted murder. One's in jail for attempted murder. So we looked at, what do you think this tells you about your grandma's ability to raise her children or parent, and compared to how she parented you? And they're both like, well, she's not that great. How, and she defends her children that are incarcerated. And it's like, well, okay. I get loving your children, but holding them responsible is something that I think a lot of parents find hard, but it's got to be done.
Well, and
So,
you're talking about intergenerational stuff. You're talking
right,
about stuff that has gone on for so long that it's hard
right.
for even a grandma who's been able to do something for her grandchildren, who probably doesn't understand that the norms of society probably left this family a long time ago.
Right.
And do your kids remember? No, we don't remember a lot of stuff that happened before we were 3 or 4. We don't
No.
have a lot of memories before we have language to associate
Right.
that memory with. So they probably don't remember. But
No.
looking back, you can fill in the blanks.
Right. So, domestic violence, I think mom just had a lot of risky behaviors. But in the CBHA, grandma's like, oh, mom has a great relationship. Mom does well. Mom's this, mom's that. It's like, okay.
Yeah.
Because the daughters first disclosed to their mom that the stepfather was abusing them sexually, and mom didn't do anything about it.
That is the story of probably every CBHA that we have written here.
Right.
So,
Right.
And it's
But-
only so good as the assessor's ability to say this is exactly what happened here.
Yeah. But come to find out, the girls, I think mom has shared with the girls that she's also been sexually abused.
More than likely. Yeah.
So, we talked about it, like maybe, mom grew up and this was normalized for her, right? So she struggled with you guys being sexually abused.
Right.
So
Exactly.
a lot of intergenerational with this one.
Right, exactly. And that's exactly what you're describing. Stephen, did you want to say something?
Yeah, you know what? I've seen also situations where like the kid isn't as traumatized as the parent thinks that they are, because sometimes when a kid gets abused, it could be a situation where like their memories begin to get repressed, so they don't even remember a lot of the event or maybe anything at all. But the parent knows that it happened, so the parent wants you to talk to the kid about it. The parent's talking to the kid about it. I feel like in a situation like that, sometimes the parent can cause them more trauma because it was something that they put in the back of their mind that they don't even know it's there, and they're bringing it to the forefront.
Well,
with this,
go ahead.
Go ahead. I was gonna say with this case, they're trying to locate the department's trying to locate mom because the kids did build a relationship with mom, had family counseling and therapeutic visits with mom in the past, so they've processed all of that. They're just back in care because grandma's emotionally abusive. So
You know, there's not a lot of kids that don't have some residual effects, even if they don't remember it. And that's really what EMDR is for. That's what some of the techniques that you're using that I know are not quite as available to you right now. Like Sandtray is really good for kind of pulling up repressed memories. There's a lot of techniques that you can use. But if you as a child have experienced some kind of domestic violence or violence or whatever, you're going to have some residual effects of it. The problem is that you're not going to remember it. So the behaviors that you have are going to reflect the fact that something happened to you, but you can't remember what it is. So, Carol, did you want to say something?
Well, yeah, and that's where, even if there isn't language or they don't remember, that's where the expressive therapies come in, even the play therapy, because that's how they're going to remember things without you even asking them.
Right. That's why we do it.
And
Yeah.
yeah,
Yeah, I think what you have to remember, and it's right there on the slide, is that early trauma is going to be your greatest predictor for future emotional difficulties. That's why the ACE test is also in your employee handbook. It's at the end. The ACE test is a great, really quick thing. I think you all know what the ACE test is. It's 10 questions. You ask that of your clients or answer it for your clients. And if there's anything over 4, the score is 0 to 10. But if your score is anything over 4, you are more than likely going to have future emotional difficulties. And we have now tested that tool on, I think at this point, over 30,000 people. So the results of it have been ongoing and consistent and fairly staggering. So Eileen's mother that was molested herself is then going to go on and have kids that are going to be molested, and grandma's going to defend people that are in jail for murder. It's just going to go on. But
Right.
look at the ACE test, and it'll be the greatest
Yeah.
predictor.
And that's one of their fears, is having kids and doing something to hurt them.
Right, absolutely. For those of you who have the DC 0 to 5 manual, for those of you who've been working with the little kids, use Axis 4. There's I don't even know what page it is, but it's Axis 4. It's a list of psychosocial and environmental stressors, and you can just go through and check off. It is a really good tool to use, even if you're trying to look at older kids, to say what happened to these kids. And it's all the psychosocial stressors that can happen to kids between the ages of 0 and 5, how many times it happened in severity. If you just do it as a little checklist for yourself, you'll get a pretty quick idea about how difficult the difficulty that these kids may be in. We use a lot of assessment tools. We have, and some of them again are in your manual. We use the PTSD questionnaire, which is a self-report. We use the ACE test. That's the easiest one to use. We have the trauma symptom checklist. The house tree person is a standardized evidence-based test, and you can score it. And if you score it, all you're saying is draw a house, draw a tree, draw a person. But I'm telling you, half of the time, if they just draw it and you eyeball the picture, you will see something in it, that something will jump out at you. So we do use a lot of these assessment tools, and that's why we put them in the manual for you to use. And again, and we're going to operationalize this coming up. There is another tool, another another billing code that you can use, especially for the little kids. It's the T1023, where you can bill for up to 9 hours of assessment. So even though Medicaid's only going to pay you for that in depth, you can bill with these tools up to 9 hours of assessment. And we just haven't operationalized it yet so that you can get paid for the work that you're doing. We use non-directive methods to assess. This is what Carol was talking about. We use Sandtray, the critter genogram, all of these things. If you go on the Circle of Friends YouTube channel and subscribe, we have a series of playlists in there, and one of them is called interventions, and they're all maybe 10-15 minute videos in which a lot of these interventions are explained. We have one for the critter genogram, we have one for the pictorial guideline. I think at this point we've got 11 of them in there. We have 2 whole separate ones that explain how to set up a sand tray, how to do sand tray, what you need in your sand tray kit. So it's a free channel. Go on and use it. We have put all kinds of playlists of books in there so that if you want to find a book for a 5-year-old on grief or death or foster care or adoption or whatever, you can go to the different playlists and pull it out. Perfect for telehealth because you can show it, share your screen, you can show it with your kids. But any of these things are going to give you some clues to the level of trauma. So you may not get your full assessment at day 20, but you can go ahead and do the assessment and we will get you paid for it, but then you can continue to assess and you'll get a much richer picture of what's happened to these kids. And you're always going to be looking at the level of trauma. You're always going to be looking at kids that are not cared for, that are witness to violence, that have been removed. And the removal is a pretty traumatic event in and of itself. If you have had anything to do with removal, if you've ever been a CPI, they're very difficult situations. There's nothing easy about going in and removing kids. And I know increasingly in counties, law enforcement has taken over that role. And you have to be a special law enforcement officer to do that because obviously law enforcement has got their mentality, they've got their way of doing things, but to be a CPI in law enforcement, you have to have the mentality of being able to, oh, thank you, Carol. Carol said the Axis 4 begins on page 153. It's a really good little checklist. The entire experience is traumatic for your kids. If you got kids in foster care and they've been removed, they've had some tough stuff. And you gotta think about some of this stuff. If you've never been a child welfare worker, if you've never been involved in any of this stuff, we just get the report after that says the child was removed and placed in foster care and blah, blah, blah. We don't know the actual reality of what happened there. And it isn't one thing. She didn't get removed because of one time that this happened. This was ongoing. There was poverty. There was domestic violence. There was obviously some alcohol and drug abuse going on there and extreme neglect of the kids. She was the one that was taking care of the brother. So the very first thing that we often did in child welfare was exactly what you saw there. That we would say, well, you know, it's Friday afternoon. We got to place this kid. We've got 2 kids, and it's a lot easier to place a baby, especially if it's a cute baby. So it's a lot easier to separate the kids. But the separation of the siblings, kids in foster care will tell you over and over again that was the worst thing that happened to them. Because think about it, the longest experience or relationship you have in your whole life is with your siblings. Your parents are probably going to die ahead of you, and your children are going to outlive you. But that group in the middle, your siblings, are the ones that you spend the most time with. So we only want to recognize that when I say what happened to this kid and somebody says he was abused, I need to know the reality of what that is. Having somebody fondle your breast once is a whole lot different than being raped repeatedly for 3 years. That kid in Jupiter, if somebody said, well, what happened to that kid? And somebody said, well, he was abused. Well, in fact, that kid was locked in a box for up to 18 hours a day for 5 years. That's a whole different level. So we need to know what happened. And for that, I go back to that slide earlier that said this is no time to be squeamish. This is a time that you've got to be able to put your own stuff aside and say, what happened and how can I help remediate it? We have to avoid those traps of rushing into the trauma narrative, and we're going to talk about that a little bit. But completing assessments child welfare style means that you might get it in time for Medicaid, but you're going to keep looking at this. And the cases, and the reason that I say that is because the assessment and the development of your goals are going to be integral. You're going to be looking at what actually happened and how do we address it first. which is where the safety thing comes in again. If you looked at Zoe, Zoe was removed, taken away from her brother, put in a foster home, probably fairly abused by the first foster mom, and didn't trust the second one at all, even though the second one had all the right moves, met her at the door with a smile, said, "Are you ready to come in? I'm so happy to see you." All the right things that foster mom did, and yet she took months to try to trust her. So we need to be able to look at these things through that trauma lens when we're trying to figure out what we're going to do here. Um, and it goes back to safety. You have got to feel safe. That's got to be your primary goal. However you write it up, whether you write that your client is 4 and he's going to pick out a bedtime safety object, or your client's 14 and he or she needs to be able to do some journaling before he goes to bed because he's scared. If you get to the CCTP training, and Eric Gentry probably says 100 times over the 2-day period, you cannot experience perceived threat in a relaxed body. What he means is that if you are physiologically relaxed, you are not going to be able to perceive threat. You're not going to see that what is right in front of you is history. You can't see that if you're in the moment. But if you can help your client to relax and feel a sense of safety, you'll get a lot farther. So again, if you haven't taken that, I encourage you to do it when it comes up. So your relationship is the most important part of this whole thing, and without that, you you can't have any treatment at all. You've got to be able to pay attention to your client. The other thing that Eric Gentry says over and over again is that you have to believe that you can help your client. And here's where faking it until you make it comes in. When you first get a client and you're trying to figure out what to do with that client, and you're trying to fill in the blanks and trying to fill in the fact that you probably don't have the whole story and probably somebody's lied to you, and you're trying to figure out what you need. If you've got nothing else when you're going in, you've got to believe that you can help this client, and you've got to instill that belief in your client. Otherwise, what are you doing there? It's no time for you to worry about yourself. And you know something, I'll tell you something that has happened with telemedicine. Because we've gotten a whole lot better at setting up our cameras and so forth, this isn't as much of an issue as it was in the beginning, but it is still an issue because you're not right in front of your client. And if you're right in front of your client and you start to think in the back of your head, what am I going to make for dinner when I get home tonight? It's pretty obvious to your client who's sitting right in front of you that you're not paying attention. But when you're on camera, it's a lot easier to you're going to miss those eye flutters and those little body movements that everybody does when they're kind of going off someplace else. So you have to be very aware of the fact that you've got to get your camera set up.
Sorry,
Go ahead.
I wanted to say something that so my mind kind of was blowing a little bit while I was watching that video, because I realized something. You know how children, when they their memory is very fleeting. Like, for example, they'll be playing with something and then they forgot that they're playing with that and they move on to something else.
Right.
So I feel like a lot of times when kids get abused, what's happening is that they did something that maybe required discipline, and then they moved on to another activity. And when they transition to the next thing, they forgot what they just did. So the parent comes, disciplines them for the thing that they did, the thing that they're not even remembering anymore. So the kid can begin to trust their parents when they're abusing them, because it's like, well, if you're hitting me, well, it has to be for a good reason. So the kid can even trust the parent while they're being abused, and they're like, oh, well, I deserve this. I deserve what's happening to me, right?
Mm-hmm.
So then they go from that, and then when they get removed from a parent, now they're dealing with these other adults that say, hey, your parent was wrong, and they don't believe you, because they're like, no, every time my parent hit me, no, like, I deserved it. Like, I don't remember what I did, but I know I did something to deserve it. Like, because they trust their parent. So now they have these random adults they've never met before making decisions for them. And that's why I think it's hard for them to trust those people, because it's like, you
Yeah.
know,
Yeah, you're absolutely right. You're absolutely right, Stephen. I mean, well, of course they don't trust anybody. Um, and that's what we mean by pathogenic care. Pathogenic care is care that is pathogenic but is perceived by kids as not pathogenic. The kid whose father has molested her, who says, "If I wouldn't do this if you didn't dress like a slut, and you're 6," is going to believe that it's their fault. Most kids believe that it is their fault. So, but you're absolutely spot on, and that's we have to kind of try to pay attention to our own body language in this stuff, because this is tough stuff. Um, let's talk a little bit about helping your client to feel safe, which means not rushing to the talk therapies. And the neurological reason for this is that the sympathetic nervous system is the one that activates all your fears. So when we talk about the sympathetic nervous system and we talk about fight or flight, the sympathetic nervous system is where all of your fears exist within your nervous system structure. What you're trying to do in the beginning is to turn off your client's sympathetic nervous system and activate the parasympathetic, because the parasympathetic is the one that is going to make them feel safe. That's why we say sympathetic is fight or flight and parasympathetic is rest and digest. So, how do you do
I
that?
got a question.
Go ahead.
Um, so if the response, instead of fight or flight, if it's freezing, like someone just freezes in the moment, is that part of sympathetic too?
Yeah, absolutely. It's just that this is somebody else's cartoon and they didn't put freezing in there, but absolutely. Fight, flight, or freeze is all part of our response. So, but like I said, I didn't draw this cartoon, so that's why it's not in there. But good question. So what are we trying to do? Why do we do some of the things that we do in the beginning? We have a lot of stuff, and you will find it on our YouTube channel. Um, we have Good Night Yoga is on our YouTube channel. Good Night Yoga is a 3-minute cartoon that has music and soothing voices and talks about all the different yoga techniques, and it will put you right to sleep, but it's a really good way to calm kids down. Most of our kids love Good Night Yoga. A lot of our kids like to do music. I have therapists who do playlists and put it on their computer, and then the kids want to play different music. We bought a whole bunch of stuff in the beginning called what was it called? Uh, the chair yoga, armchair yoga. We bought all these armchair yoga cards where you could all pick the card and the kid could sit in front of you in the chair on telemedicine and do the yoga techniques. But does this look like playing? Does this look like it's silly? Does it look like it's not helping the kid? It's helping the kid calm down. It's helping the kid achieve a sense of safety. And it's a very different way of working than the way most of us were taught in school, which is to get right in there, start talking, get them to tell you what happened. And I think what has happened over probably the 20-year period as we're really looking at this is that we recognize that the neurological state of our kids when they come to us is really in that fight, flight, or freeze mode, and we have to help them to calm down. So we use all these things that were at our disposal much more easily when we were in front of them, but we have ways to do it on telemedicine that will help you learn how to help the kids calm down. Um, and then we can get to that trauma treatment plan, but we have to integrate in the treatment plan. If you always just look in however way you write it, your first problem has got to be getting the kid to feel safe. And somebody said, I think it was one of you, I don't know, that you can become that safety figure. You can just use yourself, that you might be safe for them. But with our littles, we've learned all kinds of things like bubble blowing and belly breathing and all of that stuff. It's all over Sesame Street. You can pull that stuff off YouTube all the time with Cookie Monster doing and Elmo doing belly breathing and bubble breathing and all of that stuff. There is stuff that you can utilize with kids. Once you get them to feel safe, you can move them into the next stage of treatment. but you've got to get them to that stage. And now you're ready to start to teach them about trauma. You can't get into this stuff until they understand that, you know how we always say trauma isn't remembered, it's relived. When you're going back to something that happened to you, you're not remembering it. You are reliving it. You are not believing that that threat is not real. You are still feeling that that threat is right there with you. That's why Gentry says you cannot experience threat in a relaxed body. If you're calm, if you're thinking, okay, I know I'm safe, then you have the safety with your therapist to go back and access that trauma. But you're going to teach your client, you're going to teach the caretaker. You can use videos, you can use worksheets, you can use cartoons, you can use whatever you want. And that's where that T1027 code comes in for you guys. Use it and use it to help the caregiver understand that this kid is going through very normal reactions to trauma. And we also, again, in step 2 of this, you have got to make your client believe that you can help them. Because if they don't have hope, why should you? I mean, if you don't have any hope, why should they? So, and teaching caregivers about the neuroscience of trauma doesn't mean they have to have a PhD after their name. It doesn't mean they have to have 4 initials after their name. And I say that all the time to parents. If you are kind and patient and supportive with your kids and present in the moment with them, you can help them to feel safe. I'm here for an hour a week. I'm going to leave. You, foster parent, are here for all the rest of the time. Be kind, be present. Recognize if they do something like the little girl threw the turntable over into the fruit orchard. Was she doing that because she was bad? She was reacting to something that happened to her. So we can teach our caregivers how to do this. They don't have to have master's degrees to do it. And also, when you're talking about teaching self-regulation skills, let's go back to the beginning of this training when we talked about addiction. Addictive parents don't teach their kids much of anything. Many of these parents are intergenerational trauma themselves, and they haven't had a lot of positive caregiving themselves. And we always say you can't give away what you didn't possess to begin with. So a lot of these kids don't have any skills at all in relationships, in any kind of problem solving. They don't know how to do basic things. We have kids come into foster care who've only eaten Happy Meals, who don't know what broccoli is, who don't know what a meal on a plate is, who don't know how to go into a bedroom at night and get into a bed. We don't think about this stuff because we didn't grow up this way. But uh, if you watch The Blind Side, I use The Blind Side in one of my trainings quite a bit. But there's a scene in The Blind Side where Michael Orr goes into the bedroom and Sandra Bullock's character, the mother, has put a bedroom together for him with a bed and a dresser and furniture and so forth. And he says to her, "Is this mine?" And she says, "Yeah." And he said, "Well, I've never had one of these before." And she said, "What, a bedroom to yourself?" And he said, "No, I've never had a bed." And she was in that scene in the movie. She's very moved by that. She has to leave because in her very, very wealthy world, they're living in a mansion in Memphis. And here's a kid who's never even had, at 16, has never even had a bed. So what we try to do with our caregivers during this stage of teaching kids self-regulation is it's not complicated. It's just teach them to be consistent, teach them to do what they say they're going to do, teach them that maybe these kids don't know how to sit at a table and eat a meal. Maybe these kids don't know what certain foods are. Maybe these kids don't know how to bathe themselves or do basic self-care skills like brush your teeth. Uh, a lot of our kids, and for those of you who've been around for the famous wetting and soiling video that we have used over the years, there is a reason that a lot of kids who come into foster care have toileting issues. There's a reason that a lot of them are encopretic or they wet the bed. And it isn't necessarily that there's anything physically wrong with them. It's because if you grow up in this kind of an environment, who teaches you how to be toilet trained? It's your caretaker. And if your caretaker is zoned out on drugs, your caretaker is not going to teach you toilet training. So we have a lot of kids who come in that don't know basic toileting skills. And that's pretty basic because that's not something that you can control. And we have had kids in foster care, we've had kids in group home settings that are older that have absolutely no idea how to control their bowels, how to take care of themselves, how to take care of their self-care needs. Girls who don't know how to use a tampon when they have their period. These are pretty basic skills that a lot of our kids do not have. And I think I just went through that one without realizing that there was a slide there. So I think what we're going to try to help our caretakers to understand at this stage is that they can help these kids just by being consistent. And we say that to our adoptive parents all the time, don't we? You've got a kid who has had no caretaking, who's now with you. He's got no attachment to you. He doesn't expect anything from you. So you say to him, okay, we're going to make chocolate chip cookies on Friday afternoon. I'm going to make spaghetti for you every Wednesday because you like spaghetti. Then you better do it because this is how caretakers can build trust. And I don't think especially our adoptive parents, don't always think that that's important. They think that what's important is the much bigger stuff. And what's important is just doing what you say you're going to do so that they can learn that you are consistent. So let's talk about trauma processing again, because trauma processing can happen in all kinds of different ways. Now, you have opened your kid, you have helped that kid feel safe, you have taught them how to take care of their basic needs, and you have taught the caretaker how to help them. So now you're at the stage where you want to process trauma. Please understand, I don't know when any of you were taught trauma processing. We have gone through a whole metamorphosis with this in the last many years. They don't have to sit down and tell you what happened to them. That is not what's important. And they're not just telling you, you know, I made this mistake in the 90s because they told us all to do trauma narratives. So we would say, well, tell me what happened to you. Well, it's not just one thing. They're talking about a whole lifetime. It's like Eileen talking about the mother not knowing that she shouldn't have been allowing her daughters to be sexually abused. It's just a whole way of life. It's a whole worldview that this family has that you're now trying to help kids to understand and realize that it's not right. I think, Eileen, you talked about doing the genogram and saying, well, gee, what do you think about your grandmother's parenting skills? You didn't say your grandma's a dirtbag. You just said, what do you think about this grandma's parenting skills? Well, they can see it right in front of them. They can draw their own conclusions. But that's trauma processing at its finest. Trauma processing can be nonverbal. You can do it through play. It's really important with little kids, if you're going to process trauma, if you let them do something that's pleasurable for them, if they're enjoying the sand tray, if they're enjoying running their fingers through the sand, if they're enjoying reading the book, if they're enjoying whatever they're doing, they can get into a relaxed body. They can get into that parasympathetic nervous system, and they can begin to explore their memories while feeling safe. And sometimes that's the only way you're going to get them to do it. Now, why did we think trauma processing was necessary? Trauma processing was something that somebody thought up, I'm not sure who, in the 90s, that we thought, and I think now we call it exposure therapy, and I know that came up in our meeting yesterday, and it chilled me just a tad. But trauma processing, we were taught that the more times you repeat the story, the less powerful the memory would be. It's a completely false premise, but the more times you say, this is what happened when my father raped me, do you think that's going to make you feel any better? Do you think it's going to become less powerful? all it does is repeatedly traumatize you as the client. And again, the problem is that a trauma memory isn't remembered as something that was happening in the past. It's not remembered as that was 3 years ago and nothing can hurt me now. A trauma memory is relived. So you need to be careful about the way you help people to understand their history. It doesn't mean they have to keep telling you this. And I can tell you in the 90s, when I was first doing some of this work, I had more than one kid say to me, Barbara, I don't want to tell this story again. I've already told the story to the police. I've already told the story to the CPI. I've told the story to the case manager. I've told the story to the judge. I don't want to tell it again. And I learned what that was all about. Eileen?
Yep. I had a client last week. I've had her for a while. She's sweet. And she's in a stable placement. Case has been closed. Her and her sister have been adopted. Great adoptive parents. And she's learned to deal with everything that's happened to her and recognize, the dysfunctional patterns and things like that. And she copes better. And then there was a sentencing hearing. And she found out that her abuser was getting less time than her father. Her father had abused one child. This man had abused three. And, it was her and her sister. So that brought up all of that back up for her.
Sure.
So it's just, I always tell my kids, like, you're going to have triggers. You're going to go through life. There's going to be times where you're going to be re-triggered. Everything's going to come back. And it's about trying to regulate and use those coping skills to control that reaction.
Yeah, and you're absolutely right. This is going to be a lifelong thing as long as you learn how to manage it. It absolutely is. And I think one of the things over the years that is absolutely horrible for kids who have been sexually molested is when the perpetrator gets off. And they get off more often than they don't. And again, we're looking at statute, we're looking at law. There's a certain threshold that has to be met in order to convict. And we all know that in this country that is not always fairly met. But very, very often with these kids, the perpetrators are not incarcerated or not found guilty. And that's a tough thing to help your kids to get over. It really is. And if you got one coming up, and I think you mentioned that the other day, it's going to be tough and you need to prepare them for it because it is tough. I want to move along because it is getting a little bit late. I don't think I sent you this whole handout. I can if you want it. There is a whole handout in one of our play therapy books on the difference between post-traumatic play and toxic play. When you are doing any kind of play therapy and trying to do trauma processing that way, play therapy can produce very dynamic post-traumatic play. Post-traumatic play that's dynamic means that the child is working through the trauma through the play. So you have a child who, back in the day when we were in front of them, who does a sand tray. And in the sand tray, there are people getting killed. And he does this 3 or 4 weeks in a row. And then eventually those people aren't getting killed anymore. Eventually people are coming in and rescuing them. And there's happy endings. That is called dynamic play. That means that child is working out that trauma through his play. Toxic play is when there is no remediation, when kids do the same thing over and over and over, and you're not seeing them reaching any kind of conclusion through their play. And again, there's a whole handout on this. I'll be happy to resend it. I forgot to do it this time. But what you need to do when you identify toxic play with your kids is that is when you begin to kind of take over the session a little bit. That is when you look at the sand tray in which the baby is now buried and nobody is coming to save the baby. And you begin to say, I wonder what would happen if somebody came and saved the baby. I wonder what would happen if there was a police officer in the area that could come and help. You can begin to rewrite that narrative for them so that they begin to see some adaptation. And again, I'm not going to spend so much time on this because it's a whole thing about play, and we're going to get into this when we do our play therapy training. But learning how to move from toxic play to dynamic play is a really important skill. And you do not have to be a certified play therapist to learn that. You just need to learn how to do play therapy. So the last step that we're looking at is termination and aftercare planning. Now here's where this gets very tough for you guys. That again, we don't get to decide the end game with these kids. We just have to support them on the journey. So you got all these different people that we talked about before. You've got the GALs and the judges and the attorneys and the case managers. And very, very often the end game gets turned around. And we don't always understand the change in the goal. We don't understand why this is happening the way it is. There have been many cases where cases have been closed in our therapeutic mind in the absolute worst way that they could for the long-term outcome for this kid. And sometimes we just have to acknowledge that. And I think most recently, and actually I finally lost this poor therapist because she had so many horrible cases like this, but these were kids who kept getting shipped off to relatives in other parts of the country that they didn't even know, while there was a perfectly good pre-adoptive family sitting right here waiting to take them. Did we think that was the right clinical decision? No, but there wasn't anything we could do about it. So that's why termination with child welfare cases can be kind of difficult for therapists. And if you need support because it was a crappy ending and you know it wasn't going to be a good ending, don't hesitate to bring that to any of your supervisors. Our terminations can be messy. And what happens with that? I talked about the concurrent goals, that for first 6 months, it's either a reunification or it's adoption. Well, now you get to the next judicial review at the 12-month mark, and very often the goal is going to change at that point. Now, sometimes that's about when we're getting ready to close the case because we've done what we can do. We've helped our client on the journey. We've helped them to accept where they are. And just as Eileen is just saying, then something really bad happens in the course of the case. The guy isn't found guilty. The father who abused the child is allowed visitation. A lot of times we just have some really awful things happen at this stage. And that's about when we're getting ready to get out. And then we find that we are in there for another 6 months. And the other thing I'm going to say to you about successful termination is something that Sarah Allen used to say. Sarah Allen was a supervisor on the West Coast for a long time. And she used to say, these kids are never going to reach a point where everything is okay. So you have to just sort of get them on the pinnacle of treatment, get them sort of stable, and get out. Because if you don't, they're going to go right back down. It's going to be one of these things, and they're always going to be going up and down, which is why sometimes we have these cases open for a very long time. And that's not always good either. So we use celebrations. We really try especially with our adoptive families, to normalize the end of counseling. We have to do this with our teenage girls a lot. People don't come with a therapist. You don't attach a therapist to your hip for the rest of your life. At some point, even though you've had bad things happen to you and you've grown up in foster care and all of this has happened, you're okay. You're going to be okay, and you're going to be able to live normally. And sometimes that's hard. Termination can be hard. Can be hard with a lot of our adoptive parents who don't want to give you up because they're so afraid to give you up. And we have to normalize. We have to prepare these people for the fact that there's going to be triggers, like Eileen just said, and they can always contact you, but you're not going to stay with them forever. And the last thing we're going to go over are the ethical issues, because there are ethical issues in dealing with these cases. We deal with them here all the time when we get these referrals for these crazy therapeutic visitation cases that is not in the kid's best interest. And we have to deal with that because ethically we can't do something that's going to hurt kids. But you are going to have these issues. You got to try to keep your personal feelings out of this. And this is kind of hard when kids are going home and to a parent that that parent did some pretty bad things to this kid. And you've really got to be able to support that client. And trust me, your feelings show. So you really got to be careful about that. And if you get to a case where the end game is something that looks so bad to you, you got to remember that we don't get all the information on this. We don't always get all the rationales. We don't get all of the information of why decisions were made. And we are not lawyers. And there have been many times that a therapist has come to me and said, I don't know how they could have done that. And we have to stop and look up the statute. You ever try to read a statute? It's like reading gobbledygook, but trying to figure out what does the statute mean and why did that judge have to make that decision? Because they have to go by law. And we're not going by law. We're going by our gut and by the way we feel. And that's not how they're making decisions. So that can be tough for our therapist. And we've got to remember that you're going to get pulled in a lot of different directions. We don't want you to get into power struggles with your teams. Just don't do it. You're not going to win anything by it. You have to remember to try to keep your boundaries. A lot of people on these teams think with their hearts and not their heads. We've seen that over and over again. We've seen case managers side with foster parents who want to adopt kids and don't think that the very well-meaning grandparent who's up there in Ohio should have the kids, so they team up or they tag team with the GAL, and we can see that they're doing it. We don't want to do that. We want to just try to maintain what we think is best for the client. And it's very easy to get involved with power struggles. If you're the kind of personality that likes to get in there and scrap with people, don't do it because you're never going to win. These are tough cases. You've been handed some tough cases. And I think you just have to remember that you're always going to be supporting the case to permanency, always. And we have to. And if it's so terrible that you think that this is illegal, awful, immoral, and unethical, you can say your piece. You can say it in a way that we will help you say it. But you can't get in there and fight about it because we just don't have that decision-making power. That's not who we are. We are there to help the child on that road to permanency. So it can be a tough job. It really can. And we just can't take sides. I'm going to there you go. I think there's a lot in this training. There's a lot to unpack in this training. You have chosen a difficult job to work in child welfare. And it does involve understanding the child welfare system. It involves understanding what happens to kids that are traumatized, what happens to their brains, how all this comes about. So we really want you to use your supervisors because we're there for you. We have a lot of meetings in the course of a month for people that are going through difficult times. Nobody is ever going to think you're stupid if you call and say, somebody asked me to do this and I don't think this is right. And we'll help you tease through it. We'll also help you to find a diplomatic way to tell your case manager that what they want you to do is kind of dumb. But we don't want to say that. So you have to deal with a team, but we're your team too. So just make sure that you use us and make sure that you let us back you up. Don't go it alone out there. That's the worst thing you can do with child welfare is to try to tackle this stuff on your own because it's complicated. It's really complicated. All right, we are done. Does anybody have any last words of wisdom that they would like to add to this party?
As difficult as it is, the rewards are amazing.
I think so. I do. I think that the reason that we chose this for the path of our agency when we started it was because it's where we needed to be. And I can also tell you, because I've done this for so many years, that I've seen it done so badly, so many times, more often than I've seen it done well. So we want you guys to have the tools that you need to do it well. And that's why we do all these trainings, because we want you to understand what you're doing. And it isn't easy. And there are times that you are going to think that these case managers and judges are totally crazy. And maybe they are. I don't know. Carol?
Well, I just have been to this training for several times. And I just really feel that every time I come to a training, even though I've been to it before, I always learn something, new or more in depth. And so I always find great value in continued learning with this.
Well, I think we learn a lot from each other. So I always appreciate it when you guys are willing to share because we do learn a lot from each other. And it is tough work. And I've always said, if you can do this, you can do anything. You really can. So everybody wants to leave and go into private practice. I'm telling you, you go into private practice after doing this, you'll be bored. All right, you guys, I hope you have a good upcoming weekend and thank you for coming and participating. And if you need anything from us, you know where we are.